comorbid substance use. Substance use disorders, especially use of alcohol, are another category of conditions that are often seen in the anxiety disorders. In their review, Kushner, Abrams, and Bocard concluded that presence of an anxiety disorder doubles to quadruples the risk of alcohol or drug dependence, with anxiety frequently preceding the alcohol use disorder and contributing to its persistence, although alcohol misuse can also lead to anxiety. However, this self-medicating assumption was not supported in a 7-year prospective study in which alcohol dependence was as likely to increase risk of developing a subsequent anxiety disorder as was the reverse temporal relationship. Kushner and colleagues concluded that anxiety and alcohol problems have reciprocal and interacting influences that will lead to an escalation of both anxiety and problem drinking. The end result can be a downward self-destructive spiral leading to helplessness, depression, and increased risk for suicide, comorbidity within anxiety disorders. The presence of one anxiety disorder significantly increases the probability of having one or more additional anxiety disorders. In fact, pure anxiety disorders are less frequent than comorbid anxiety. In their large clinical study, Brown, DiNardo, Lehman, and Campbell found that comorbidity for another anxiety disorder ranged from 27% for specific phobia to 62% for post-traumatic stress disorder. Generalized anxiety disorder, GAD, was the most common secondary anxiety disorder, followed by social phobia. For PTSD, which had the highest comorbid rate for another anxiety disorder, panic disorder and GAD were the most common secondary anxiety conditions. Social phobia and GAD tended to precede many of the other anxiety disorders. Analyses of lifetime diagnosis revealed even higher rates for occurrence of a secondary anxiety disorder. Prevalence. The anxiety disorders are the most prevalent form of psychological disturbance. Epidemiological studies of adult community samples have been remarkably consistent in documenting a 25 to 30% lifetime prevalence rate for at least one anxiety disorder. For example, the 1-year prevalence for any anxiety disorder in the NCS was 17.2%, compared with 11.3% for any substance abuse dependence and 11.3% for any mood disorder. The NCS lifetime prevalence, which includes all individuals who ever experience an anxiety disorder, was 24.9%, but this may be an underestimate because OCD was not assessed. In a recent replication of the NCS involving a nationally representative sample of respondents interviewed between 2001 and 2003, 12-month prevalence of any anxiety disorder was 18.1% and estimated lifetime prevalence was 28.8%, findings that are remarkably similar to the first NCS. National surveys conducted in other Western countries like Australia, Great Britain, and Canada have also reported high rates of anxiety disorders in the general population, although the actual prevalence rates vary slightly across studies because of different interview methodologies, diagnostic decision rules, and other design factors. The World Health Organization WHO World Mental Health Survey initiative found that anxiety was the most common disorder in every country except Ukraine, with 1-year prevalence ranging from 2.4% in Shanghai, China, to 18.2% in the United States. Anxiety disorders are also common in childhood and adolescence, with 6-month prevalence rates ranging from 6% to 17%. The most frequent disorders are specific phobia, GAD, and separation anxiety. Some disorders like social phobia, panic, and generalized anxiety significantly increase during adolescence, whereas others like separation anxiety show a decrease. Girls suffer higher rates of anxiety disorders than boys. Comorbidity between anxiety and depression is high, and anxiety disorders that arise during childhood and adolescence often persist into early adulthood. Individuals suffering from anxiety disorders often first come to the attention of family physicians in primary care settings because of unexplained physical symptoms like non-cardiac chest pain, palpitations, faintness, irritable bowel syndrome, vertigo, and dizziness. These complaints may reflect an anxiety condition such as panic disorder. Moreover, patients with anxiety disorders seek out medical advice in disproportionate numbers. Studies of primary care patients find that 10 to 20% have a diagnosable anxiety disorder. Slad and Rubin found that anxiety was mentioned in 30% of visits to a university medical clinic family practice. Anxiety disorders then place a considerable burden on health service resources. A large percentage of general adult population experiences occasional or mild symptoms of anxiety. There is some evidence that individuals are at increased risk for developing a full-blown anxiety disorder if they experience panic attacks, sleep disturbance, or have obsessional concerns that are not sufficiently frequent or intense to meet diagnostic criteria, or have high anxiety sensitivity. Worry, the cardinal feature of GAD, is reported by a majority of non-clinical individuals who express concerns with work or school, finances, family, and the like. Problems with sleep are reported by 27% of British women and 20% of British men. In the United States 1991 National Sleep Foundation survey, 36% of participants had occasional or chronic insomnia. Other studies indicate that 11 to 33% of non-clinical students and community adults have experienced at least one panic attack in the last year. Thus, symptoms of anxiety and its disorders are prevalent problems that threaten the physical and emotional well-being of a significant number of people in the general population. Gender differences. Women have a significantly higher incidence of most anxiety disorders than men, with the possible exception of OCD, where the rates are approximately equal. In the NCS, women had a lifetime prevalence of 30.5% for any anxiety disorder, compared with 19.5% for men. Other community-based and epidemiological studies generally have confirmed a 2:1 ratio of women to men in prevalence of anxiety disorders. Since these gender differences were found in community-based surveys, the preponderance of anxiety disorders in women cannot be attributed to greater service utilization. In a critical review of research on gender differences in the anxiety disorders, Krask concluded that women may have higher rates of anxiety disorders because of an increased vulnerability such as 1. Higher negative affectivity. 2. Differential socialization patterns in which girls are encouraged to be more dependent, prosocial, empathic, but less assertive and controlling of everyday challenges. 3. More pervasive anxiousness as evidenced by less communicating and more overgeneralized anxious responding. 4. Heightened sensitivity to reminders of threat and contextual threat cues. And or 5. Tendency to engage in more avoidance, worry, and rumination about potential threats. Cultural differences. Fear and anxiety exist in all cultures, but their subjective experience is shaped by culture-specific factors. Cross-cultural generalizability is not necessarily improved by using the World Health Organization's classification of anxiety disorders, the International Classification of Diseases 10th revision, because of the dominance of the European-influenced Western experience. Thus, our standard diagnostic and assessment approaches to anxiety may overemphasize aspects of anxiety that are prominent in the European Western experience and omit significant expressions of anxiety that are more culture-specific. Barlow concluded in his review that apprehension, worry, fear, and somatic arousal are common in all cultures. For example, a large community survey of 35,014 adult Iranians found that 20.8% had anxiety symptoms. Even in remote rural or mountainous regions of developing countries where modern industrial amenities and pressures are minimal, the occurrence of anxiety and panic disorders is similar to rates reported in Western community surveys. Nevertheless, countries do appear to have different population rates of the anxiety disorders. The WHO World Mental Health Surveys found that 1-year prevalence of DSM-4 anxiety disorders ranged from a low of 2.4, 3.2, and 3.3% in Shanghai, Beijing, and Nigeria, respectively, to 11.2, 12, and 18.2% in Lebanon, France, and the United States, respectively. This broad variability in prevalence rates raises the possibility that culture may influence the actual rate of anxiety disorders across countries, although methodological differences across sites cannot be ruled out as an alternative explanation of the differences. There is substantial evidence that culture does play a significant role in the expression of anxious symptoms. Barlow noted that somatic symptoms appear more prominent in emotional disorders in most countries other than those of the European-influenced West.